Enhanced recovery after surgery, the ERAS protocol. Professor Ioana Grigoraș. Anesthesia and Intensive Care Department. University of Medicine and Pharmacy, GR.T. Popper. Regional Institute of Oncology. Iași, Romania. Factors influencing patient recovery. Accelerated recovery. Pre-op information. Optimized organ function. No nutritional defects. No alcohol pre-op. Stop smoking pre-op. Neuraxial blockade. Minimally invasive surgery. Normothermia. Nausea prevention. Ileus prevention. Early feeding. Good oxygenation. Good sleep. Opioid sparing. Evidence-based post-op care. Anxiety, fear. Pre-op organ dysfunction. Surgical stress response. Hypothermia. Nausea, vomiting. Ileus. Semi-starvation. Hypoxemia. Poor sleep. Drains and tubes. Catheters. Delayed recovery. Enhancing recovery after GI surgery. What is ERAS? Standardized protocol for perioperative care. Multimodal intervention. Reduce operative stress. Support organ function. Reduced morbidity. Accelerate convalescence. Functional capacity. Days, weeks. Modify sterile perioperatory IAL capacity functional. Intervention multimodal, analgesi, nutritienterala, strategy to reduce era stress perioperator, mobilizer, Keva controller physiologia postoperatory RCAC consequent to reduce area morbidity C acceleraria convalescenti. Traditional care. Enhanced recovery. Henrik Kiehlet, B.R.J. Anast 1997, 78, 606. What is ERAS? Standardized protocol for perioperative care. Multimodal intervention. Pre-op. Information. Stress attenuation. Pain relief. Exercise. Enteral nutrition. Nurses. Surgeons. Anesthesists. Dietitian. Kinesiotherapist. Modify sterile perioperatory IAL capacity functional. Intervention multimodal, analgesi, nutritienterala, strategy to reduce era stress perioperator, mobilizer, Keva controller physiologia postoperatory RCAC consequent to reduce area morbidity C acceleraria convalescenti. Multidisciplinary approach. Henrik Kiehlet, B.R.J. Anast 1997, 78, 606. Early removal of catheters/drains. Epidural anesthesia. Periop fluid. Management. Remifentanil. No pre-med. DVT prophylaxis. Pre-op counseling. No bowel prep. Early. Mobilization. CHO loading / no fasting. ERAS. Perioperative. Nutrition. Incisions. Bear hugger. Null tubes. Prevention. Of ileus / prokinetics. Early removal of catheters / drains. Oral analgesics / NSAIDs. Lassin et al., Arch Surge, 2009. Outline. Anesthetist approach. Surgeon approach. Protocolization. Outline. Anesthetist approach. Surgeon approach. Protocolization. enhanced recovery in practice. Fluid management. Postoperative glycemic control. Postoperative nutrition. Early mobilization. Rapid hydration, nourishment. Appropriate for therapy. Catheters removed early. Regular oral analgesia. Avoid opiates. Referral from primary care. Preoperative. Admission. Optimized medical conditions. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. Operative. Antimicrobial prophylaxis. Multimodal analgesia. PONV. Optimal fluid therapy. Hypothermia prophylaxis. Postoperative. Follow-up. Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. UO Gustafsson et al. Clinutr 2012, 31, 783-800. Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. UO Gustafsson et al. Clinutr 2012, 31, 783-800. Pre-admission education and counseling. Patient information. Pre-admission education and counseling. Decrease fear and anxiety. Improve wound healing. Perioperative feeding. Postoperative mobilization. Pain control. Reduce the prevalence of complications. Enhance postoperative recovery and discharge. Detailed information given to patients before the procedure about surgical and anesthetic procedures may diminish fear and anxiety and enhance postoperative recovery and quicken hospital discharge. 14,15 A preoperative psychological intervention, aimed at decreasing patient anxiety, may also improve wound healing and recovery after laparoscopic surgery. 16,17 Personal counseling, leaflets or multimedia information containing explanations of the procedure along with tasks that the patient should be encouraged to fulfill may improve perioperative feeding, early postoperative mobilization, pain control, and respiratory physiotherapy, and hence reduce the prevalence of complications. 18E20 Ideally, the patient and a relative/care provider should meet with surgeon, anesthetist and nurse. UO Gustafsson et al. Clinutr 2012, 31, 783-800. Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. UO Gustafsson et al. Clinutr 2012, 31, 783-800. Preoperative improvement of physiological function. Prehab. Preoperative improvement of physiological function. Increasing exercise preoperatively. Walk. Training programs. Although anesthetic and surgical techniques have improved over the years, the incidence of serious postoperative complications has not declined greatly during recent decades. Pulmonary, cardiovascular and infectious complications still cause extended hospital stay, intensive care admittance, and risk of death for a relatively high proportion of patients recovering from surgery. Recent research has given us new tools for preventing postoperative complications by revealing the relationship between lifestyle and postoperative complications. Further, it has been shown that intervention is capable of reducing the risk of serious complications. 1. A weekly alcohol intake exceeding 35 units is also associated with an increased risk of postoperative complications. Again, infections and cardiopulmonary complications are increased, as well as serious bleeding episodes. Wound healing is impaired, resulting in wound and anastomotic dehiscence. In such patients, total abstinence for at least 4 weeks before surgery reduces the perioperative risk to normal levels. Preoperative improvement of physiological function. Prehab. Preoperative improvement of physiological function. Increasing exercise preoperatively. Walk. Increasing distance. Increasing duration. Increasing frequency. Easier to implement. Psychological preparation. Motivation, adherence to exercise. Less efficient. Although anesthetic and surgical techniques have improved over the years, the incidence of serious postoperative complications has not declined greatly during recent decades. Pulmonary, cardiovascular and infectious complications still cause extended hospital stay, intensive care admittance, and risk of death for a relatively high proportion of patients recovering from surgery. Recent research has given us new tools for preventing postoperative complications by revealing the relationship between lifestyle and postoperative complications. Further, it has been shown that intervention is capable of reducing the risk of serious complications. 1. A weekly alcohol intake exceeding 35 units is also associated with an increased risk of postoperative complications. Again, infections and cardiopulmonary complications are increased, as well as serious bleeding episodes. Wound healing is impaired, resulting in wound and anastomotic dehiscence. In such patients, total abstinence for at least 4 weeks before surgery reduces the perioperative risk to normal levels. Preoperative improvement of physiological function. Prehab. Preoperative improvement of physiological function. Increasing exercise preoperatively. Training programs. Although anesthetic and surgical techniques have improved over the years, the incidence of serious postoperative complications has not declined greatly during recent decades. Pulmonary, cardiovascular and infectious complications still cause extended hospital stay, intensive care admittance, and risk of death for a relatively high proportion of patients recovering from surgery. Recent research has given us new tools for preventing postoperative complications by revealing the relationship between lifestyle and postoperative complications. Further, it has been shown that intervention is capable of reducing the risk of serious complications. 1. A weekly alcohol intake exceeding 35 units is also associated with an increased risk of postoperative complications. Again, infections and cardiopulmonary complications are increased, as well as serious bleeding episodes. Wound healing is impaired, resulting in wound and anastomotic dehiscence. In such patients, total abstinence for at least 4 weeks before surgery reduces the perioperative risk to normal levels. Prehab Hughes A. JAMA. 2006 296 15. 1851 to 1857. Although anesthetic and surgical techniques have improved over the years, the incidence of serious postoperative complications has not declined greatly during recent decades. Pulmonary, cardiovascular and infectious complications still cause extended hospital stay, intensive care admittance, and risk of death for a relatively high proportion of patients recovering from surgery. Recent research has given us new tools for preventing postoperative complications by revealing the relationship between lifestyle and postoperative complications. Further, it has been shown that intervention is capable of reducing the risk of serious complications. 1. A weekly alcohol intake exceeding 35 units is also associated with an increased risk of postoperative complications. Again, infections and cardiopulmonary complications are increased, as well as serious bleeding episodes. Wound healing is impaired, resulting in wound and anastomotic dehiscence. In such patients, total abstinence for at least 4 weeks before surgery reduces the perioperative risk to normal levels. Eusebio A. JAMA. 2006 296 15, 1851–1857. Prehab RCT, N equals 279. High-risk Peach Single Center, 2002–2005. Pre-hospitalization period before CABG surgery may be used to improve a patient's pulmonary condition. Although anesthetic and surgical techniques have improved over the years, the incidence of serious postoperative complications has not declined greatly during recent decades. Pulmonary, cardiovascular and infectious complications still cause extended hospital stay, intensive care admittance, and risk of death for a relatively high proportion of patients recovering from surgery. Recent research has given us new tools for preventing postoperative complications by revealing the relationship between lifestyle and postoperative complications. Further, it has been shown that intervention is capable of reducing the risk of serious complications. 1. A weekly alcohol intake exceeding 35 units is also associated with an increased risk of postoperative complications. Again, infections and cardiopulmonary complications are increased, as well as serious bleeding episodes. Wound healing is impaired, resulting in wound and anastomotic dehiscence. In such patients, total abstinence for at least 4 weeks before surgery reduces the perioperative risk to normal levels. Eusebio A. et al. JAMA. 2006 296 15, 1851–1857. Prehab. Postoperative pulmonary complication time of postoperative hospitalization. Although anesthetic and surgical techniques have improved over the years, the incidence of serious postoperative complications has not declined greatly during recent decades. Pulmonary, cardiovascular and infectious complications still cause extended hospital stay, intensive care admittance, and risk of death for a relatively high proportion of patients recovering from surgery. Recent research has given us new tools for preventing postoperative complications by revealing the relationship between lifestyle and postoperative complications. Further, it has been shown that intervention is capable of reducing the risk of serious complications. 1. A weekly alcohol intake exceeding 35 units is also associated with an increased risk of postoperative complications. Again, infections and cardiopulmonary complications are increased, as well as serious bleeding episodes. Wound healing is impaired, resulting in wound and anastomotic dehiscence. In such patients, total abstinence for at least 4 weeks before surgery reduces the perioperative risk to normal levels. Eusebio A. JAMA. 2006 296 15, 1851–1857. Preoperative alcohol consumption. Increase, X3, in postoperative morbidity. Cardiopulmonary complications. Bleeding. Wound infections. Recent data have shown alcohol misusers to have a 3-fold increase in postoperative morbidity. Abstinence from alcohol for 1 month before surgery reduces postoperative morbidity after colorectal surgery. Mechanisms may involve reduced responses to surgical stress and improved cardiac and immune dysfunction. Withdrawal from alcohol before an operation is recommended in alcohol abusers. Alcohol abusers have a 2- to 3-fold increase in postoperative morbidity, the most frequent complications being bleeding, wound and cardiopulmonary complications. 1 month of preoperative abstinence reduces postoperative morbidity by improving organ function. Tunasen et al. BRJ Surg 1999 86 to 869 to 74. Preoperative alcohol consumption. Abstinence from alcohol for 1 month before surgery reduces postoperative morbidity. After colorectal surgery, recent data have shown alcohol misusers to have a 3-fold increase in postoperative morbidity. Abstinence from alcohol for 1 month before surgery reduces postoperative morbidity after colorectal surgery. Mechanisms may involve reduced responses to surgical stress and improved cardiac and immune dysfunction. Withdrawal from alcohol before an operation is recommended in alcohol abusers. Alcohol abusers have a 2 to 3-fold increase in postoperative morbidity, the most frequent complications being bleeding, wound and cardiopulmonary complications. 1 month of preoperative abstinence reduces postoperative morbidity by improving organ function. Does it any difference? Gustafsson et al. Clinic 2012. 31, 783 to 800. Preoperative alcohol consumption. Nature. SPO 2. Postoperative ECG and pulse oximetry. Ischemia %. Recent data have shown alcohol misusers to have a 3-fold increase in postoperative morbidity. Abstinence from alcohol for 1 month before surgery reduces postoperative morbidity after colorectal surgery. Mechanisms may involve reduced responses to surgical stress and improved cardiac and immune dysfunction. Withdrawal from alcohol before an operation is recommended in alcohol abusers. Hypoxemic episodes. Arrhythmias. Tunasen et al. BMJ 1999. 318 to 1311 to 6. Preoperative alcohol consumption. Mean BP. Plasma noradrenaline. Mean HR. Plasma adrenaline. Responses to surgical stress. Recent data have shown alcohol misusers to have a 3-fold increase in postoperative morbidity. Abstinence from alcohol for 1 month before surgery reduces postoperative morbidity after colorectal surgery. Mechanisms may involve reduced responses to surgical stress and improved cardiac and immune dysfunction. Withdrawal from alcohol before an operation is recommended in alcohol abusers. Serum cortisol. Plasma IL-6. Plasma glucose. Tunasen et al. BMJ 1999, 318 to 1311 to 6. Preoperative alcohol consumption. Alcohol consumption should be stopped 4 weeks before surgery. Recent data have shown alcohol misusers to have a 3-fold increase in postoperative morbidity. Abstinence from alcohol for 1 month before surgery reduces postoperative morbidity after colorectal surgery. Mechanisms may involve reduced responses to surgical stress and improved cardiac and immune dysfunction. Withdrawal from alcohol before an operation is recommended in alcohol abusers. Alcohol abusers have a 2 to 3-fold increase in postoperative morbidity, the most frequent complications being bleeding, wound and cardiopulmonary complications. 1 month of preoperative abstinence reduces postoperative morbidity by improving organ function. Gustafsson et al. Clinic 2012, 31, 783 to 800. Preoperative smoking increased postoperative morbidity. Cardiopulmonary complications. Wound infections. Daily smokers, greater than 2 cigarettes daily for 1 year, have an increased risk of pulmonary and wound complications. RCTs have demonstrated reductions in the rates of both types of complications 1 month after cessation of smoking. Lindstrom D. et al. And Surge 2008, 248 to 739 to 45. Anesthesia, 2009. Preoperative smoking cessation 4 weeks before surgery. RCTN equals 117, blinded outcome assessment. Hernia, cholecystectomy, hip/knee replacement. Smoking cessation 4 weeks before surgery. Postoperative complications. 41% versus 21%. Smoking abstinent after 1 year. 33% versus 15%. Daily smokers, greater than 2 cigarettes daily for 1 year, have an increased risk of pulmonary and wound complications. RCTs have demonstrated reductions in the rates of both types of complications 1 month after cessation of smoking. Lindstrom D. et al. And Surge 2008, 248 to 739 to 45. Anesthesia, 2009. Preoperative smoking meta-analysis, 11 RCTs, 1,194 pints. The harmful effects of tobacco smoking are well known, but its effect on surgical risk has only recently been demonstrated. The physiological effects of smoking imply changes in cardiovascular, pulmonary, immune and wound healing functions. In patients undergoing elective orthopedic surgery, the incidence of cardiovascular complications was twice as high in smokers as in non-smokers, and clinically important infections were 3 times as common in smokers. An individual smoking intervention program imposed 6-8 weeks prior to surgery is highly effective in reducing surgical complications. 2. T. Thompson et al. BRJ Surge 2009, 96, 451 to 461. Preoperative smoking any complication. T. Thompson et al. Interventions for preoperative smoking cessation. Cochrane Database of Systematic, 2010, 7. CDO 02294. Preoperative smoking wound complications. T. Thompson et al. Interventions for preoperative smoking cessation. Cochrane Database of Systematic, 2010, 7. CDO 02294. Smoking should be stopped 4 weeks before surgery. Preoperative smoking. Smoking should be stopped 4 weeks before surgery. Daily smokers, greater than 2 cigarettes daily for 1 year, have an increased risk of pulmonary and wound complications. RCTs have demonstrated reductions in the rates of both types of complications 1 month after cessation of smoking. Gustafsson et al. Clinutr 2012, 31, 783 to 800. Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. Gustafsson et al. Clinutr 2012, 31, 783 to 800. Bozzetti, Nutrition, 2002, 18 to 953. Norman, Clinical Nutrition, 2008, 27, 515. Questions regarding perioperative nutrition. TNP versus N? Pre versus post versus pre and postoperative? Standard versus immunonutrition? ESPN recommendations. Preoperative. All malnourished patients. All cancer patients. Scheduled for upper gastrointestinal surgery. no matter the nutritional status. Preoperative enteral, immunonutrition. For 10 to 14 days. Recommendation Grade A. Aspen recommendations. Perioperative. Only moderately/severely malnourished patients scheduled for elective surgery. Impossibility of meeting nutritional needs greater than 7 to 14 days. Early postoperative enteral, delayed PN, nutrition, rationale for preoperative nutritional support. Pro. Malnourished peds at risk of postoperative complications. Reduced nutrient intake frequent in cancer peds and correlates with nutrition status and complications. Although malnutrition usually develops over weeks/months, a short course of nutrition support can improve physiologic functions. Preoperative nutrition support better tolerance for postoperative nutrition. Preoperative glucose-reduced postoperative insulin resistance. Rationale for preoperative nutritional support. Con. The nutritional status of cancer patients correlates with disease stage and cancer control. If nutritional depletion is the result of metabolic use of nutrients, the benefit. Short-term refeeding, reversal of long-term malnutrition. Preoperative nutrition increases the length of preoperative stay and increases the costs. Who should receive preoperative nutrition support? The patient should be moderately/severely malnourished. The procedure should be one in which nutrition support has been shown to improve outcome, thoracoabdominal surgery. Surgery should be elective and safe to delay for 7–10 days. The enteral route is always preferred, when possible. Combination with postoperative nutrition. Immune-enhancing formulas, preoperative nutrition. Malnourished patients should receive nutritional support. Oral supplements. Enteral nutrition. Immunonutrition 5–7 days preoperatively. Reduce the prevalence of infectious complications in patients undergoing major open abdominal surgery. In Western countries, patients scheduled for PD are, in general, not malnourished, and usually present with less than 7% weight loss. 31 In such cases, preoperative artificial nutrition is not warranted. The situation may be different in other regions. It is widely accepted that significantly malnourished patients suffer increased postoperative morbidity after major surgery. 32E34 Preoperative supplements with oral sip feeds or enteral tube feeds are usually administered in these cases, but scientific evidence to support this routine, as opposed to no nutritional support, is lacking. Extrapolating data from studies in the postoperative setting suggests that parenteral nutrition should be used only if the enteral route is inaccessible. Summary and recommendation: routine use of preoperative artificial nutrition is not warranted, but significantly malnourished patients should be optimized with oral supplements or enteral nutrition preoperatively. The role of IN has been investigated thoroughly over many years. Few studies specifically address IN for PD patients, and the variation in active immune-modulating nutrients administered makes interpretation difficult. A reduction in the prevalence of infectious complications is a consistent finding in patients with gastrointestinal cancer, as are beneficial effects on surrogate endpoints, levels of interleukins and C-reactive protein, CRP, or LOSH. A reduction in mortality has not been shown. Several recently published reviews and meta-analyses conclude that there is a benefit from perioperative and postoperative in patients undergoing major gastrointestinal surgery, but results remain inconsistent. Beneficial outcomes have been shown in a systematic review of 35 trials in patients undergoing elective surgery, in which arginine-supplemented diets were associated with a significantly reduced prevalence of infectious complications and LOSH. There is also evidence to suggest that immunomodulating nutrition may be more beneficial in undernourished rather than in normally nourished patients. However, Indiana could be detrimental in patients with sepsis. 46 There are no trials investigating in within ERAS care pathways. Summary and recommendation. The balance of evidence suggests that IN for 5-7 days perioperatively should be considered because it may reduce the prevalence of infectious complications in patients undergoing major open abdominal surgery. Kalasin et al. ClinNutr 2012, 31, 817-830. Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. Gustafsson et al. ClinNutr 2012, 31, 783-800. Preoperative fasting. While it is desirable that there should be no solid matter in the stomach when chloroform is administered, it will be found very salutary to give a cup of tea about 2 hours previously. Joseph Lister. On Anesthetics. Holmes System of Surgery. Volume 3, 3rd ed. London, Longmans Green and Company, 1883. Lundqvist and Saw-Eyed, B.R.J. Surge. 2003. 90, 400-406. Preoperative fasting. Standard practice, fasting from midnight. Reduce the volume and acidity of stomach contents. Decrease the risk of pulmonary aspiration. But Lundqvist and Saw-Eyed, B.R.J. Surge. 2003, 90, 400-406. Preoperative fasting. Standard practice, fasting from midnight. But reduce the volume and acidity of stomach contents. Decrease the risk of pulmonary aspiration. But Cochrane review of 22 RCTs. Fasting from midnight. No reduction in gastric content. No rise in pH of gastric fluid. Clear fluids until 2 hours before anesthesia. Thirst, headaches, hunger. The most common surgical practice of making patients NPO, nilperos, after midnight of the day of any planned surgical procedure has been recently questioned. However, Brady et al. Reviewed 38 randomized controlled trials on perioperative fasting and concluded that there was no evidence to suggest overnight fasting for fluids results in a decrease in perioperative aspiration risk or related morbidities. Brady M. et al. Cochrane Database Sistrev 2003, 4, CD 004423. Why challenge fasting by midnight? Normal physiology is no guarantee of an empty stomach. The same gastric volume with/without clear fluids. Improved well-being. Thirst, headaches, hunger. Preoperative fasting. Standard practice. Fasting from midnight. Reduce the volume and acidity of stomach contents. Decrease the risk of pulmonary aspiration. Modern fasting guidelines. Clear fluids 2 hours before anesthesia. Exclusions. Emergency surgery. Year J. Anesthesiology 2011 28 to 556 to 569. What are the effects of the preoperative fasting? Preoperative fasting and perioperative fluids. If fasted, risk of dehydration. Dehydration and anesthesia, greater than hypotension. Hypotension, greater than more fluids infused. Overload of fluids. Pre-op clear fluids, greater than less for fluids, greater than improved outcomes. Gustafsson et al. Arch Surge, 2011. Metabolic effects of overnight fasting. Day. Night. Hormones. Insulin plus. Insulin dash. Glucagon. Cortisol. Substrates. Storage. Breakdown. Utilization. CHO greater than fat. Fat greater than CHO. Lundqvist et al. Scan J. Nutr. 2004, 48, 77-82. Surgical stress. Insulin resistance. Insulin sensitivity falls with the magnitude of surgery. More. Insulin resistance. Percentage, %. Thoralu et al. Kerop Inclin Nutrimetab Care 1999, 269. Insulin resistance cause complications. Elective cardiac surgery, N equals 273. Diabetics and non-diabetics. Complications increase with insulin resistance. 50% reduction in insulin sensitivity. 5 to 6-fold increase risk of complications. 10-fold risk for infections. Sato et al., JSOM 2010, 95, 4338-44. Can we change the metabolism? Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. Uo Gustafsson et al. ClinNutr 2012, 31, 783-800. Carbohydrate treatment. 20% glucose 4. 12.5% carbohydrate drink. 400 milliliters 2 hours before anesthesia. Plus 800 milliliters evening before. Induce insulin release. Aims, insulin response. Insulin resistance is one of the most fundamental reactions to injury and stress. 1. In response to an injury, the activation of the neuroendocrine and inflammatory systems very rapidly, within minutes, sets the body in a metabolic state of stress. This includes a halt of anabolic processes, and instead substrates from all bodily stores, fat, carbohydrate, and protein, are released and made available as fuels, as building blocks for acute phase proteins or tissue healing. Central to this potentially massive change in metabolism is the development of insulin resistance. Insulin is the body's most important anabolic hormone, and to achieve the rapid mobilization of substrates, insulin actions are reduced. In surgical patients, the degree of insulin resistance is related to the magnitude of the operation. 1. In major surgical procedures, such as major colorectal operations, up to 90% of the preoperative insulin sensitivity can be lost after the operation. This change in metabolism lasts for well over 1 week, even after moderate surgical stress. What is now becoming more and more evident is that insulin resistance is one of the key mechanisms by which several common surgical complications are triggered. Traditionally, insulin resistance was regarded as the way the body should respond to stress, and for the most part it was believed that it was probably beneficial and purposeful and should not be interfered with. Indeed, in studies of certain situations of severe stress, insulin resistance can be a key for survival. This is true in acute hemorrhage, where insulin resistance is needed to mobilize glucose to achieve fluid movements and plasma refill, too. However, in contrast to this, recent studies in elective surgical patients have suggested that in modern surgical practice, insulin resistance is harmful by prolonging recovery. 1. And in this issue of Sato et al. 3, present a very important study showing a clear relationship between insulin resistance and postoperative complications. What is the effect of the carbohydrate drink? Setting before surgery. Fasted. CHO fed. Hypoglycemia. Dash. Plus. Insulin sensitivity. Plus 50%. Glucose production. Peripheral glucose uptake. Plus. Lundqvist et al., ClinNutr 2001, Svanfeldt et al. ClinNutr 2005. Carbohydrate treatment. 20% glucose 4. 12.5% carbohydrate drink. 400 ml 2 hours before anesthesia. Plus 800 ml evening before. Safety. Carbohydrate treatment. Gastric emptying is complete in 90 minutes for CHO, water. 120. 90. 60. 30. 20. 40. 80. 100. CHO, N equals 6. Water, N equals 6. Isotope activity in the stomach, percent. Minutes after intake. Nigren et al., and Serge, 1995. Oral intake of CHO does not increase gastric volumes. Gastric volume, ml. Acidity, pH. Overnight fast, N equals 89. 6 to 41. 1.6 to 4.0. Placebo. N equals 86. 12 to 35. 1.6 to 2.5. CHO 12.5%, N equals 80. 7 to 41. 1.6 to 2.7. 400 milliliters 12.5% carbohydrate-rich drink, 360 musm/kg. Housel et al., Anasthanalj 2001. Carbohydrate treatment. 20% glucose 4. 12.5% carbohydrate drink. 400 milliliters 2 hours before anesthesia. Plus 800 milliliters evening before. Safe, fast gastric emptying. Pre-op CHO reduces postoperative insulin resistance. Control. Percent change from pre-op. More. Resistance. Nigren et al., Kerop in ClinNutriMetab Care 2001. Pre-op CHO activates muscle insulin signaling pathways. Wang et al., BJs 2010. Pre-op CHO maintains postoperative muscle anabolic pathways. Wang et al., BJs 2010. Preoperative CHO retains lean body mass, MAC. SM. P less than 0.05. Yu et al., ClinNutr 2005. 66. Effects of preoperative carbohydrates. Reduces the metabolic stress of surgery. Effectively reduces insulin resistance. Improves pre/postoperative well-being. Improves postoperative muscle function. Reduce lean body mass losses. May result in faster recovery. What type of carbohydrates? Clear. Carbohydrate. Drink. ONS 400, 70 grams ONS dissolved in water to 400 milliliters. ONS 300, 70 grams ONS dissolved in water to 300 milliliters. Amount ingested. 400 milliliters. 300 milliliters. Amount of carbohydrate. 50 grams. Amount of protein. 0 grams. 15 grams glutamine. What type of carbohydrates? Preoperative carbohydrates. Year J Anesthesiology. 2011 28 to 556 to 569. Preoperative carbohydrates meta-analysis. Length of stay. The traditional practice of overnight fasting has definitively been shown to be unnecessary, and numerous anesthesia societies have now changed their guidelines to permit more liberal fluid intakes 47 up to 2 hours prior to induction of anesthesia. Findings from the present meta-analysis indicated preoperative carbohydrate treatment was not associated with an increase in drink-related complications, confirming the safety of utilizing oral complex carbohydrate drinks of appropriate osmolality preoperatively. Several countries have already updated their preoperative guidelines to recommended preoperative carbohydrate treatment due to its perceived beneficial effects on insulin resistance and well-being. 48. This meta-analysis also suggests that, in addition to the aforementioned benefits, faster recovery, decreased length of hospital stay, in patients undergoing open major abdominal surgery may also be expected. Preoperative carbohydrate treatment, as part of a multimodal enhanced recovery protocol, is recommended by the Enhanced Recovery After Surgery, ERAS. 1 day shorter length of stay for major abdominal surgery, N equals 762. No difference in minor short stay surgeries, less than 3 days, N equals 380. No difference in orthopedic surgery, N equals 32. Awad et al., ClinNutr 2013, 32. 34 to 44. All recent guidelines recommend oral carbohydrate loading. Germany 2003, major surgery. Anesthetist. 2003 November, 5211, 1039 to 45. Scandinavia 2005, major surgery. Actu anesthesiol scanned. 2005 September, 49-8, 1041 to 7. Espen 2005, major surgery. ClinNutr. 2006 April, 25-2, 224 to 44. Espen 2009, major surgery. ClinNutr. 2009 May 20th. United Kingdom 2009, elective surgery. J Intensive Care Society. 2009 10-1, 13 to 5. European SOC Anesthesiology 2011, elective surgery. Year J Anesthesiology. 2011 28 to 556 to 569. Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. Gustafsson et al. ClinNutr 2012. 31, 783 to 800. Pre-anesthetic medication. Education. Avoid starvation. CHO loading. No sedative medication. Before surgery. Short-acting 4 drugs. Prior epidural/spinal analgesia. Gustafsson et al. ClinNutr 2012, 31, 783 to 800. Preoperative ERAS components. Patient information. Health/medical optimization. Nutrition. Fasting time. Carbohydrate drinking. Pre-anesthetic medication. Antithrombotic prophylaxis. Gustafsson et al. ClinNutr 2012, 31, 783 to 800. Anti-thrombotic prophylaxis. Risk in colorectal surgical patients. DVT -30%, P -1%. Mechanical. Pharmacological. Compression stockings in all patients. Intermittent pneumatic compression. LMWH. For 28 days. In cancer patients. Gustafsson et al. Clinutr 2012, 31, 783 to 800. Intraoperative ERAS components. Antimicrobial prophylaxis. Anesthesia protocol. PONV. Fluid management. Hypothermia prophylaxis. Intraoperative ERAS components. Antimicrobial prophylaxis. Anesthesia protocol. Multimodal analgesia. PONV. Fluid management. Hypothermia prophylaxis. Antimicrobial prophylaxis. Imperative to reduce the risk of surgical infections. Time. 30 to 60 minutes before the incision. Repeated doses. During prolonged procedure, greater than or equal to. Massive blood loss/fluid loading. Route. Intravenous. Spectrum. Suspected germs, aerobic plus minus anaerobic bacteria. Intraoperative ERAS components. Antimicrobial prophylaxis. Anesthesia protocol. PONV. Fluid management. Hypothermia prophylaxis. Anesthetic protocol target, rapid awake of the patient. Anesthesia technique. Balanced anesthesia. TIVA. Short-acting agents. Hypnosis, propofol, sevoflurane, disflurane. Analgesia, sufentanil, remifentanil. Myorelaxant, cisatracurium. Algesimeter pupillaire pour le monitorage de l'analgesie. Intraoperative monitoring. BIS. Hypnosis. Muscle. Relaxation. Cardiac output. Glucose. Analgesia. Algiscan. TOF. ERAS. Esophageal. Doppler. Glucometer. Intraoperative ERAS components. Antimicrobial prophylaxis. Anesthesia protocol. Multimodal analgesia. PONV. Fluid management. Hypothermia prophylaxis. Multimodal analgesia, epidural analgesia for analgesia. Wound catheters/infiltration. Peripheral blocks. Benefits of epidural analgesia. Dynamic pain control. Obtunes stress response. Reduction of ileus. Reduced postoperative pulmonary complications. Reduced myocardial ischemia. Reduced incidence of DVT/P. Causes of ileus, degree of surgical manipulation. Magnitude of inflammatory and stress response. Sympathetic reflexes. Opioids. Fluid overload/bowel edema. Epidural analgesia versus 4 opiates GI function. ADA results in less GI paralysis. Jorgensen-Cochrane database Sistrev 2004. Intraoperative ERAS components. Antimicrobial prophylaxis. Anesthesia protocol. Multimodal analgesia. PONV. Fluid management. Hypothermia prophylaxis. PONV risk factors: patient, female, non-smokers, motion sickness. Anesthetic, volatile agents, 4 opioids, nitrous oxide. Surgical, Major abdominal surgery. PONV scoring systems. Multimodal approach. Pharmacological. Non-pharmacological techniques, TIVA, minimal fasting, CHO loading, adequate hydration, epidural, and SEDS. Intraoperative ERAS components. Antimicrobial prophylaxis. Anesthesia protocol. Multimodal analgesia. PONV. Fluid management. Hypothermia prophylaxis. Perioperative fluid management. Is fluid therapy vital for outcome? Are the fluid requirements the same? What about fluid shifts? What amount? What type of fluid? Is there an indication for vasopressors? When 4 fluids should be discontinued? Is fluid therapy vital for an optimal outcome after surgery? Post-op weight gain following colorectal resection. KCH Fearon 2004. Post-op weight gain following colorectal resection. 3 to 6 kilograms. Lobo et al., Lancet Brandstrup et al., 2002. 359, 1812-18 Annals Surg 2003, 238, 641-8. Perioperative fluid management. DO2 equals CO, SVXHR, X count 2 by 10. Bungard-Nielsen, et al. Actuanus scans 2009. 53, 843-851. Preoperative carbohydrates, fluids and outcomes. Main factors for better outcomes. Pre-op carbohydrates and fluid balance. Pre-op carbohydrates, greater than. Less fluid overload, 450 milliliters. For every liter extra, 32% increased risk of complications, cardiovascular. Limit, day of surgery, colonic 3000 milliliters, rectal 3500 milliliters. Gustafsson et al., ArchSurg 2011, fluid requirements are different. Open laparotomy. Increase fluid shifts. Bowel handling. SIRS. Laparoscopy. CO reduction. Head down position. Pneumoperitoneum. Fluid shifts should be minimized. Avoid bowel preparation. Maintain hydration till 2 hours before surgery. Minimize bowel handling. Avoid blood loss. Exteriorization outside the abdominal cavity. The use of cardiac output, surrogate. Goal-directed therapy. The use of cardiac output, surrogate. To guide for fluid. Alone or in combination with inotropics during the perioperative period. Goal-directed intraoperative fluid therapy. Noblet et al., BJ's 2009. Meta-analysis based on amount of fluid given. Less than 1.75 liters/24 hours, greater than 2.75 liters/24 hours. Varadhan K., Proc. 2010. Fluids, recent meta-analysis. Rabari NN, BJ's 2009, 96, 331. Types of fluids: crystalloids and colloids. Body water compartments. 59% reduced risk for complications. Varadhan K., Proc. 2010. 59% reduced risk for complications. 3.4 days reduction in hospital stay. Perioperative fluid management. Fluid therapy is vital for outcome. Fluid requirements are different. Fluid shifts should be minimized. Fluid administration must be goal-directed. The types of fluids: crystalloids and colloids. Vasopressors are indicated in hypertensive normovolemic patients. IV fluids should be discontinued as soon as practicable. Intraoperative ERAS components: antimicrobial prophylaxis, anesthesia protocol, multimodal analgesia, PONV, fluid management, hypothermia prophylaxis, hypothermia prophylaxis. Hypothermia, central temperature less than 36 C. Risk factor 4. Wound infections, prolonged cicatrization. Cardiac events. Shivering, increase O2 consumption. Bleeding. Coagulation disorders. Thrombocytes dysfunction. Postoperative ileus. Increase pain. Prolong emergence time. Hypothermia prophylaxis. Hypothermia, central temperature less than 36 C. Methods: warming devices, forced air warming blankets, warm 4 fluids, warm gases in laparoscopic surgery. Postoperative ERAS components: postoperative analgesia, fluid management, postoperative glycemic control, postoperative nutrition, early mobilization. Postoperative analgesia, optimal analgesic regimen, good pain relief, reduction of cardiovascular, cognitive, endocrino, metabolic complications in at-risk patients, decrease the risk of chronic pain, allow early mobilization, allow early return of gut function and feeding. Postoperative analgesia. Principles of multimodal analgesia. Avoidance of 4 opioids. Regional anesthesia techniques. Thoracic epidural analgesia, TA. Spinal analgesia. Local anesthetic techniques. Transversus abdominis plane, TAP, block. The analgesic regimen is specific to the type of surgery/incision. Postoperative analgesia in open surgery. Thoracic epidural anesthesia, TA. Middle thoracic, T7-T10. Superior analgesia in the first 72 hours. Earlier return of gut function. Postoperative analgesia in open surgery. Thoracic epidural anesthesia, TEA. Low dose concentration of local anesthetic. Short-acting opiate. Maintained for 48-72 hours postoperative. Efficacy of postoperative epidural analgesia, a meta-analysis. Block BM et al., JAMA. 2003 29018, 2455-2463. Epidural analgesia versus opiates. GI function. ADA results in less GI paralysis, versus 4 opiates. Jorgensen-Cochrane database Istrev 2004. Postoperative analgesia in laparoscopic surgery. Spinal analgesia. Low-dose long-acting opioid morphine. Recent publications have shown that the duration of pain after laparoscopic surgery requiring major analgesics is much shorter than for open surgery, thereby allowing discharge from hospital as soon as 23 hours after surgery. Provided early feeding is tolerated in the laparoscopic group, analgesic requirements at 24 hours postoperatively are often addressed with oral multimodal analgesia without the need of regional blocks or strong opiates. Modification of ERAS in lap surgery. RCT ADA versus spinal versus PCA, N equals 91. Lap colorectal surgery. Loss. ADA, 3.7 D, longer than PCA and spinal, 2,8 and 2,7 D. Spinal. Faster return of bowel function, versus ADA and PCA. Earlier tolerance of food, versus ADA. Levy, BJs, 2011. ERAS and lap colorectal resection. One Centre, North Bristol, UK. N equals 606, 2004 to 2009. Primary anastomosis. ERAS formerly after 2008. Transversus abdominis plane, TAP, or rectus sheath block. No ADA or PCA. Card withdrawn in theatre. 46% discharged within 3 days, median loss 4 days. 2 same day, 70 within 24 hours. 116 within 48 hours, 91 within 72 hours. Readmission rates 4%. Gash kilojoules, colorectal dis, 2012. Early removal of card during ADA. During thoracic epidural anesthesia. Removal of card in the morning after surgery. Or after removal of ADA. RCT, N equals 205. No increased need for recatheterization. Transient increase in post-void residual volume, UL scanning. Zyuta, Actuanest scanned, 2012. Postoperative ERAS components. Postoperative analgesia. Fluid management. Postoperative glycemic control. Postoperative nutrition. Early mobilization. 59% reduced risk for complications. Varadam K, Procnutsoc, 2010. 59% reduced risk for complications. 3.4 days reduction in hospital stay. Postoperative ERAS components. Postoperative analgesia. Fluid management. Postoperative glycemic control. Postoperative nutrition. Early mobilization. Postoperative glycemic control. Hypoglycemia in surgical stress. Insulin resistance is the key. Traditional belief. Hypoglycemia in the acutely stressed patient is not dangerous. Glucose levels treated more than 200 mg/dl. Hypoglycemia can be avoided. Elective major surgery. Opportunity to prevent/attenuate metabolic responses to surgery, rather than having to treat them with insulin. Several stress-reducing interventions in ERAS. Attenuate insulin resistance as single interventions. Preoperative oral carbohydrate treatment. Epidural blockade. Minimally invasive surgery. If interventions are combined in ERAS protocol, hypoglycemia can be avoided. Even during full enteral feeding starting immediately after major colorectal surgery. Postoperative ERAS components. Postoperative analgesia. Fluid management. Postoperative glycemic control. Postoperative nutrition. Early mobilization. Postoperative nutrition. Fluids immediately after recovery from anesthesia. Normal hospital food on day 1. Traditional care. Enhanced recovery protocol. Nigrenclin Nutr 2003. Postoperative early enteral nutrition. No increased risk of anatomotic leaks, reduce risk of infection and loss. Without multimodal and ischelius therapy, increased risk of vomiting. Wathas, upper major GI surgery, jejunostomy. Lewis et al. BMJ 2001 323 7316, 773-6. Postoperative ERAS components. Postoperative analgesia. Fluid management. Postoperative glycemic control. Postoperative nutrition. Early mobilization. Early mobilization affects conditions early return of bowel function. Improved digestive tolerance. Enhanced anabolism. Decreased risk of venous thromboembolism. Decreased risk of pulmonary complications. Enhanced recovery. Conditions. Good analgesia. No ventilatory support. No postoperative somnolence. Psychological support. Outline. Anesthetist approach. Surgeon approach. Protocolization. It is ironic that the American Society of Anesthesiologists, whose members are critical observers of surgical procedures, evolved the best index of operative risk. Arthur S. Keats, Anesthesiology 1978. Perhaps the American Surgical Association, whose members are critical observers of anesthetic procedures, will provide us with a meaningful index of anesthetic risk. Arthur S. Keats, Anesthesiology 1978. Surgeon, anesthetist, no bowel prep food after surgery. No drains or card. No 4 fluids, no lines. Early discharge. All evidence-based. Anesthetist. Carbohydrates. No fasting. No pre-medication. Epidural anesthesia. Balanced fluids. Vasopressors. No or short-acting opioids. Evidence-based medicine. Surgeons. Tradition. Evidence-based medicine. Bowel preparation pro-con avoids massive contamination. Minor inconvenience to the patient. Looks better inside. Con. Preoperative dehydration. Modification of enteral flora. Delayed gut motility. Conclusions: 7 trial URI 1300 pints. Arch surge. 2004 December, 13912, 1359-64, discussion 1365. Mechanical bowel preparation for elective colorectal surgery, a meta-analysis. Butcher P., Mermelod B., Gervas P., Morel P. Conclusions: 7 trial URI 1300 pints. There is no evidence to support the use of MBP in patients undergoing elective colorectal surgery. Available data tend to suggest that MBP could be harmful with respect to the incidence of anastomotic leak and does not reduce the incidence of septic complications. Rectal cancer, TME, total mesorectum excision. Standardized Enhanced Recovery Program. For the Enroll trial. Day before surgery, avoidance of oral bowel preparation except in patients undergoing total mesorectal excision, TME, and reconstruction. Kennedy et al. BMC Cancer 2012, 12-181. Reduce surgical injury, minimally invasive surgery. Fast-track surgery. Early postoperative recovery. Decreased stress response. Decreased inflammatory response. Decreased pain. Early bowel movement, shortens hospitalization. Fast track. Early rehabilitation. Minimally invasive surgery. Not mandatory for fast track surgery. But shortens hospitalization. No routine nasogastric tube. 28 multi-center trials greater than 4,000 pints. decreased duration of postoperative ileus, decreased risk of postoperative pulmonary complications, increased patient call, no increase in anastomotic leak. Nelson, R., et al. Systematic review of prophylactic nasogastric decompression after abdominal operations. B.R. J. Surge, 2005, 92, 673 to 680. No drains. Rationale of drains: when in doubt, drain. A surgical tradition. Difficult to be abandoned. For how long? 24 hours, 48 hours, 7 days. In majority of cases, serous drained fluid. Physiological reabsorption. When in doubt, drain. Lawson Haight, English surgeon. The drain equals the surgeon eye in the patient's abdomen. No drains. RCTs, unreliable indication of anastomotic leak. Underestimates the significance of anastomotic leak. Underestimates the postoperative bleeding. Does not influence the rate of anastomotic leak. Increases the contamination risk. Prolongs the duration of postoperative ileus. Prolongs the hospital length of stay. Petrowski, H., et al., Evidence-based value of prophylactic drainage in gastrointestinal surgery, a systematic review and meta-analysis. Ann. Surge, 2004, 240, 1074 to 1085. Day of surgery, postoperative period. 4 fluids, if clinically indicated. Pressors for epidural hypotension. Regular preemptive antiemetics, ondansetron as first line. Early mobilization, patient sits up. Starts drinking protein drinks. Colonic surgery. Day 1, Day 2, urinary catheter removed in the morning. 8 hours of enforced mobilization. Resumes normal diet. Preemptive oral analgesia is started. Paracetamol and NSAIDs. Avoid opioids. Day 2. Epidural infusion is stopped in the morning. Epidural catheter is removed at 14.00 if pain controlled and timed with anticoagulant dose. Colonic surgery is an important target for patients and staff, but flexibility is vital. Day 3/4, discharge criteria. Return of GI function. Able to eat and drink without discomfort. Passing flatus. Pain controlled with oral analgesia. Adequate home support. Discharge date is an important target for patients and staff, but flexibility is vital. Colonic surgery, the surgeon the cornerstone of fast track and ERAS programs. Outline. Anesthetist approach. Surgeon approach. Protocolization. Preoperative optimization, preoperative nutrition, preoperative fasting. Carbohydrates. Treatment. Properative. Prophylaxis. Preventing. Hypothermia. Analgesia. Fluid management. PONV. Fluid management. Postoperative. Nutrition. Early mobilization. Analgesia. 1. ERAS. Results. Randomized trials. Meta-analysis. ERAS compliance and outcomes. 953 consecutive colorectal surgery patients. Multivariate analysis, ERAS factors. Carbohydrate treatment. 44% reduced risk of symptoms delaying discharge, PONV, pain, GI symptoms, dizziness. 16% reduced risk of wound dehiscence. Fluid balance, for each extra liter. 16% increased risk of symptoms delaying discharge. 32% increased risk of complications. Gustafsson et al. Arch Surge, in Press 2011. ERAS, Clinical Outcome. Review of 6 RCTs, N equals 452. Complications. Reduce complications by 50%. Review of 6 RCTs, N equals 452. The results from the present meta-analysis suggest that the implementation of 4 or more elements of the ERAS pathway leads to a reduction in length of hospital stay by more than 2 days. However, there was significant heterogeneity for the effect of ERAS on the length of hospital stay and hence, could potentially weaken the treatment effect. Varadhan et al. ClinNeut. 2010, 29, 434-440. ERAS, Clinical Outcome. Review of 6 RCTs, N equals 452. Mortality. Of the 452 patients, 4 died during the 30-day follow-up period, with 1 death, myocardial infarction, in the ERAS group and 2 myocardial infarctions and 1 pulmonary embolism, in the traditional care group. Varadhan et al. ClinNeut. 2010, 29, 434-440. ERAS, Clinical Outcome. Review of 6 RCTs, N equals 452. Length of stay. Shorter length of stay by 2.5 days. Review of 6 RCTs, N equals 452. The results from the present meta-analysis suggest that the implementation of 4 or more elements of the ERAS pathway leads to a reduction in length of hospital stay by more than 2 days. However, there was significant heterogeneity for the effect of ERAS on the length of hospital stay and hence, could potentially weaken the treatment effect. Varadhan et al. ClinNeut. 2010, 29, 434-440. Experimental group equals enhanced recovery after surgery, ERAS. Readmissions, days. No significant difference was noted in readmission rates. Experimental group equals enhanced recovery after surgery, ERAS. Control equals traditional care, TC. JAMA surgery. 2011. International Journal of Colorectal Disease. Fast-track rehabilitation after colonic surgery in elderly patients, is it feasible? International Journal of Colorectal Disease. Volume 22, Number 12, December, 2007. M. Scharfenberg 1, W. Raw 1, T. Jungens 1 and W. Schwenk 1. Conclusion: using the fast-track rehabilitation program on elderly patient is not only feasible but may also lower the number of general complications and the duration of the hospital stay. Ioana. Fast-track concepts in major open upper abdominal. World J Surge. 2011 September 1st. Fast-track concepts in major open upper abdominal and thoracoabdominal surgery, a review. Fagervik Olsen M. Wenberg E. 15 articles. Gastric, n equals 2. Pancreatic, n equals 5. Hepatic, n equals 2. Esophageal, n equals 3. Aortic surgery, n equals 3. Cephas P. HMJ, 2007 Volume 1, Number 2165 to 174. Successful Fast-Track Surgery Program. Anasthanalj 2007 104, 1380 to 1396. Copyright 2007 International Anesthesia Research Society DOI 10.1213010.000263034.96885.E1. Ambulatory anesthesia. The role of the anesthesiologist in fast-track surgery. From multimodal analgesia to perioperative medical care. Paul F. White, Ph.D., M.D., Henrik Kiehlet, M.D., Ph.D. and the Fast-Track Surgery Study Group. Conclusion: the decisions of the anesthesiologist as a key perioperative physician are of critical importance to the surgical care team in developing a successful fast-track surgery program. Original article. Current perioperative practice in rectal surgery in Austria and Germany. Till Hasenberg, Friedrich Langel, Bianca Reibenwein, Karen Schindler, Stefan Post, Claudia Spies, Wolfgang Schwenk, and Edward Schang. International Journal of Colorectal Disease 2010. Volume 25, Number 7, 855 to 863, DOI 10.1000/S0038401009000-2. Results. The response rate -63% A, 76 centers, +30% G, 385 centers. Mechanical bowel preparation, abandoned by 2% G and 7% A surgeons. Nasogastric decompression tubes, rarely used. 4/5 of the questioned surgeons use intra-abdominal drains. Half of the surgical centers, intake of clear fluids on the day of surgery. Mobilization, in half of the centers on the day of surgery. Epidural analgesia, 3/4 of the institutions. Institutions which have implemented fast-track rehabilitation. Discharge earlier. Surgery and perioperative care remains heavily based in tradition. Practice varies substantially internationally. Survey of UK general surgeons. There is inadequate multidisciplinary and community support to initiate ERAS. Never heard of it. Survey regarding practice across European countries. Nil by mouth. Almost abandoned in others. This is the biggest challenge facing the wide implementation and acceptance of ERAS programs. Hill, Andrew, 2008, December 10. Enhanced Recovery After Surgery. Cytopics. http://www.cytopics.com/enhanced_recovery_after_surgery.html. Multimodal care programs. Current evidence supports the potential role of multimodal care programs in the promotion of early recovery from major surgical trauma. To achieve the desired outcome targets, all elements of the protocol must function. A committed, multidisciplinary approach is essential. And a simple, but effective implementation and reinforcement strategies are necessary. Implementation in practice, CHC de Jong, Netherlands. http://www.span.jp/doc6/sec7.html. Implementation of the ERAS protocol. Select a target. Invite participation to create a team. Explain what you are trying to achieve. Select an expert group. Create change concept and priorities. Implement strategy. Regular review to measure and evaluate change. Review strategy. Implementation in practice, CHC de Jong, Netherlands. http://www.span.jp/doc6/sec7.html